This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Abyssinian tea. Want to know what substance is used by 20 million people a day worldwide, but is almost unknown in Western countries? What movie might have influenced U.S. drug policy? And what plant's potency decreases rapidly once it's picked? Listen to find out. Today's episode starts in the emergency department. Your intern presents the case of a 45-year-old man with chest pain, noting the patient has had intermittent pain for the past few days. Today, the pain became intractable, prompting his visit. He notes the pain increases with exertion, like walking, and improves with rest, i.e. sitting down. The pain radiates to his left arm and his left neck. It's associated with sweating and some shortness of breath. She sums up the history of present illness by saying it's a classic presentation of what kind of chest pain. That's question number 1. A, acid reflux or a stomach ulcer. B, aortic dissection or a tear in the aorta. C, myocardial infarction or a heart attack. D, a collapsed lung. C, this is the classic description of myocardial infarction or a heart attack, specifically the location of the pain radiating to the neck and the arm, and especially the pain exacerbated by exertion and improved with rest. In fact, it sounds like several days of angina with concern now for a heart attack. You agree with her assessment. Moving on to the past medical history, she notes, however, the patient doesn't have many typical cardiac risk factors. He is over age 40, but doesn't have a history of hypertension, diabetes, high cholesterol, or even a significant family history. He's not overweight. You ask about his last medical visit. Some patients avoid a diagnosis of comorbidities because they don't see doctors or practitioners to have their blood pressure and blood work checked, though, side note, this doesn't work in their favor. She notes normal primary care screenings in the recent past. She says his physical exam is unremarkable and moves on to his EKG. It shows T-wave inversions, non-specific, but they can indicate ischemia. She treated him with aspirin and nitroglycerin. His chest pain is now resolved. She's still awaiting his lab results, specifically a troponin, to determine if indeed this is a heart attack. You agree with her excellent handling of the case and go to see the patient. Walking in the room, you recognize both the patient and his wife. They own your favorite Yemeni coffee shop, a popular local hangout, and one you visit routinely to fuel up on the way into shifts for extra large coffees with extra shots of espresso. The patient is sitting comfortably on the stretcher. He gives you the same history as the intern. He denies taking any medicines, anything over the counter, or any supplements. His vital signs are as follows: temperature 98.6 Fahrenheit or 36.9 Celsius, heart rate 112 beats per minute, blood pressure 150 over 98, respiratory rate 18 with an oxygen saturation of 100% on room air. So mildly elevated heart rate and blood pressure. You examine him, noting brown discoloration of his teeth. He seems to have a few green leaves stuck in them, but otherwise you agree with the intern, it's unremarkable. You tell him and his wife you're waiting for the lab results. You exit the room and move on to the next patient. An hour later, the resident stops you in the hall telling you his troponin is high. She diagnoses him with an NSTEMI or a non-ST elevation MI. She says the history fits, but is still surprised given his lack of risk factors. You and the intern return to the room to discuss the results, the diagnosis, and the next steps, including admitting him to the hospital. His heart rate and blood pressure are back to normal. The patient, who was perfectly calm and pleasant, is now cranky and irritable, refusing to stay in the hospital and complaining about the IV in his arm hurting. He starts pulling off the monitor leads attached to his chest. Seems surprising, given that at the coffee shop he's always been warm and hospitable. But one of the difficult parts of emergency medicine is seeing patients at their worst on oftentimes their worst day. Sometimes they're in pain, sometimes they're anxious and fearful. They feel terrible. They fear the diagnosis we might give them. They fear the cost of medical care. They feel mortality, morbidity, like not being able to take care of their families, and probably 1,001 other concerns. The patient's wife speaks to him in what you assume to be Yemeni and slaps the monitor leads back down on his chest. The patient calms down, saying he'll stay, but he doesn't seem at all happy about it. When you step out of the room, his wife follows, pulling the door shut behind her and asking for another minute of your time. She insists on apologizing for the patient's cranky behavior, though you insist there's no need. She says it's due to his frequent use of something which he hasn't had for the several hours in which he's been in the emergency department. Question number 2, and time to pick your poison. What substance is causing our patient's symptoms? A, caffeine. B, cocaine. C, hashish. D, khat. The answer, this is D, cot. Certainly caffeine withdrawal could make our patient cranky, a situation with which I'm extremely familiar and you may have suffered from as well. Massive amounts of caffeine are required for toxicity. Even if he drinks tons of coffee per day, it's not enough to make him caffeine toxic. He doesn't or didn't have other signs, including shakiness and a narrow pulse pressure, meaning a small gap between the upper and lower numbers on the blood pressure. Cocaine definitely causes heart attacks and withdrawal symptoms, but his initial presentation wasn't consistent with a significant sympathomimetic toxidrome. He was only very mildly tachycardic and hypertensive and not sweating. Hash is cannabis, and there's a lot of interesting recent data showing that cannabis significantly increases the risk of heart attacks, but it doesn't really cause these withdrawal symptoms. Leaving us with khat. What's khat? It's a plant from East Africa and the Arabian Peninsula. It has many names, and the names have many different spellings. Often you'll see it Khat, but it can be Chat or Gaat, just to name a few. It's also called Abyssinian tea or Arabian tea. So, did I hear you ask, is there an antidote? Well, let's talk about what it is and what it does, and then come back to this question. Khat's Latin name for the plant is Catha edulis. It's a bush or a small tree. Khat use is extremely popular in the Horn of Africa and the Arabian Peninsula, especially in countries like Yemen, Ethiopia, and Somalia. It's noted to be particularly popular in Muslim countries where alcohol is outlawed. Khat use is very social. It's often used in cafe settings like coffee shops, most commonly by men, promoting friendship and business connections. In some places, it's reported 90% of men use it. And it's even used by children as young as 12 and commonly in school students because it improves alertness and concentration. It's so prevalent in Yemen, one person reported during the war hostilities stopped between 1 and 4 p.m., a popular time for using khat. I seriously doubt that's true, but it does make an interesting point about use patterns and ubiquity. What is true is that a study at a hospital in Yemen noticed an interesting pattern in the presentation of heart attacks. In non-users, the peak presentation times of heart attacks was in the early hours of the day, but khat users had heart attacks more frequently in the late afternoon and the evening, concurrent with the time khat is most commonly used. Question number 3. Khat is primarily used in which form? A, pill, B, powder, C, gum, D, leaves. The answer is D, leaves. Khat is most commonly used by chewing the fresh green leaves, and it's typically sold in bundles or bags of leaves. Users chew the leaves and leave them inside their cheek, kind of like chewing tobacco. A rideshare driver of mine once had green leaves in his teeth. It could have been anything, but it was probably khat he was using to stay awake. Unlike tobacco, users typically swallow the liquid. It's said to have a bitter, astringent taste, so it's often taken with tobacco and sugary drinks or sugar cubes. A typical quantity is 100 to 200 grams of leaves in a session. Symptom onset occurs in about 30 minutes after chewing and typically lasts for around 3 hours. Users' teeth are often stained brown from the juice, as with our patient, and there is an increased risk of cavities, tooth loss, and oral cancers. What's in khat? Well, it's actually a naturally occurring cathinone. You might have heard of cathinone or its synthetic derivatives like methcathinone, the drugs in bath salts during the early 2000s. Cathinone is a phenylethylamine. It's related to amphetamines as well as epinephrine and norepinephrine. Leaves can contain anywhere from 30 to 100 milligrams of cathinone per 100 grams of leaves. It's a natural product, obviously, so it's no surprise that the potency varies with location, climate, etc. Cathinone itself has about half the potency of amphetamine. Knowing khat is related to amphetamine, you can guess its effects. It works similarly by inhibiting the reuptake of epinephrine and norepinephrine in nerve endings, resulting in increased levels of these neurotransmitters, and in turn causing increased blood pressure and heart rate. It causes mild euphoria, increased alertness, and decreased appetite. Gastrointestinal effects can be fairly prominent, including constipation, gastritis, and stomach ulcers. The effects are relatively mild. It's often compared to drinking a strong cup of coffee. There's a debate as to whether or not khat is truly addictive. There are definitely withdrawal symptoms reported. It appears to have the side effect of moderate psychological dependence, but without physical dependence symptoms. According to the World Health Organization, it's less addictive than alcohol and tobacco. But as we know in toxicology, it's really the dose that determines the poison. So back to the question of an antidote. No, there is no antidote. We do treat things like cocaine intoxication and other sympathomimetic toxidromes with benzodiazepines to give a sedative effect. If the patient had a hypertensive emergency, for example, uncommon but possible, I would use benzodiazepines. But khat's effects only last for a few hours, as I said earlier, so you're not really likely to be treating the compound directly, but rather treating its effects, as our intern did in this case by administering the treatment for heart attacks. Chronic use of khat can result in psychosis, though it's typically reversible with stopping. There's an increased risk of heart attack, especially in younger patients aged 30s to 40s. And this risk occurs with frequent use and/or an underlying predisposition. There's an increased risk of stroke. Long-term use is also associated with liver problems, including hepatitis and cirrhosis. Why do users prefer fresh leaves? Better taste? No, actually, a better high. Cathinone starts to break down as soon as the leaves are harvested. It's converted to caffeine, which is way less potent. In fact, in the U.S., cathinone is a Schedule 1 drug versus caffeine, which is a Schedule 4 drug. All right, question number 4. This is a bit of an aside, but it's today's pop culture consult. What movie depicts khat use and has been said to have influenced khat becoming a Schedule 1 drug in the United States? A. Zero Dark 30, B. Black Hawk Down, C. Lawrence of Arabia, or D. Captain Phillips? The answer is B. Black Hawk Down. Somali fighters high on khat are shown in the movie about Marines in Mogadishu. Is this really true? Cathinone was made Schedule 1 in the United States the same year the movie was released, 1993. Coincidence? Some people think not. My first thought was that the idea of American drug enforcement policy being influenced by the movies was completely ridiculous. Then I remembered reefer madness about marijuana in the 1930s, so who knows? Your guess is as good as mine. But anyway, back to the facts. People can and do use dried leaves in powder, but it's not as potent. This leads to interesting issues with distribution. If you're using the fresh leaves, you need a bunch or a bag of them per single session, and it's hard to smuggle a big quantity of fresh plants into a country. This isn't like a highly concentrated fentanyl powder, for example, that can be cut when it reaches its destination. Khat is legal in much of the Middle East and East Africa, like in Yemen and Ethiopia, but it's not legal in the US, the UK, and it's very restricted in Canada. If you look online, you'll see pictures of bundles of slender red branches wrapped in banana leaves. These bundles of khat are often in duffel bags, and the photos are from law enforcement after confiscation at the airport, for example. You can get dried leaves which have been smuggled in as tea and powder, reported on shipping manifests, for example, as henna. The fresh leaves are preferred, as I said. Khat is a very valuable cash crop, leading to higher revenue than coffee. It grows in similar regions, but khat can be harvested 4 times a year and coffee only once. However, it does use a significant amount of water, raising environmental and humanitarian concerns in places like Yemen and Ethiopia where water is in short supply. 1 bag of khat leaves can require 130 gallons or 500 liters of water to grow. It's estimated that 20 million people worldwide use khat on a daily basis, with the Yemeni market alone being estimated to be worth $12 billion US. One seller, for example, said he sells 150 pounds or 70 kilos of leaves per day. It's not cheap anywhere in Africa, Arabia, or in the West. It is more expensive, of course, in places where it's illegal. And a bundle of fresh leaves in the UK can sell for as much as 30 or 40 pounds per bag. Occasionally, allegations khat is used to fund terrorist organizations arises, though as far as I know, they haven't been actually substantiated. Back to our patient. You tell him about the link between khat and heart disease, making him more irritable. Khat isn't associated with physical withdrawal symptoms, like opioids, for example, but some users do report symptoms after stopping, with mild depression, dysphoric moods, irritability, and increased appetites. The symptoms don't affect everyone, and they typically last for hours to days. The patient is admitted to the hospital for further care by cardiology. Khat use is a very, very old social custom in East Africa and Arabia. Use dates back at least as far as the 11th century when it was noted in a Persian medical reference. The author of this reference wrote that khat was a, quote, coolant, it relieved biliousness, and it was a refrigerant for the stomach and the liver. And its use in medicine isn't just ancient history. French, English, and Swiss pharmaceutical companies touted khat as a drug in the early 1900s, but interestingly enough, its use failed due to difficulties with transport of fresh leaves during World War I. In 1958, a Yemeni revolutionary and poet named Muhammad Mahmud al-Zubairi gave this colorful description of khat as a devil that, quote, made the Yemeni people lust after it and is fighting in their stomachs against valuable nutrients for the human body. Then it runs in their veins like Satan and enters their pockets to steal their money, end quote. It's a very vivid imagery. A week later, you see your patient and his wife at the coffee shop. You're happy to note his teeth are less stained and there's no green leaves in his mouth. For the next few months, you have to turn down their generous offers of free coffee and pastries at the cafe. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. That brings us to the end of the podcast and to the last question. What writer compared the use of khat in the East to tea drinking in Europe? A. Charles Dickens, B. Mark Twain, C. Rudyard Kipling, D. Thomas de Quincey. Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.